Greetings from Wilmed Group of Institutions. Today we are taking interactive sessions for our registered candidates. I repeat, this is not a course, this is not a class right now what we are conducting, but an interactive session for those who are already on server and are taking different, server-based courses, and those candidates are having questions at regular intervals. So here we are taking these interactive doubt clearance sessions for registered candidates. Please make a note that I will not show much of the clips, the ultrasound images, because these are in detail in our courses. I will be taking just questions, the doubts, and explanation if any required in any topic or any subject. We have got questions from our registered candidates. So the first question is, you can read the question over here. Now, these are the copy-pasted questions. What I mean by copy-paste, as we got the question, we just copied and pasted, so the language is original. This is the first question by Dr. Kiran Singh, who is from Lucknow. Endometrial thickness measurement in value in different phases of life. Now, I'm elaborating the question. As I told you, these are the original question. The language is original. These are copy-pasted message questions from our candidates. The candidate, Kiran Singh, wants to know about the endometrial thickness and the values in different phases. Now, the phases of life is one, and the phases of cycle is second. I will take both. So here it is not very much clear whether it is for the phase of life, like what will be the measurement in childhood, then adolescence, and so on. And second is the phase of cycle. That is completely different. So I will be taking both a phase of life as well as the phase of cycle. Just bear with me. Yeah. Now, first of all, let's discuss the endometrial thickness measurements in different phases of the cycle. First of all, in menstrual phase, you all know it is very thin because the endometrium is thin due to the shed off. Here, the in menstrual phase, it will be about 2 to 4 millimeters. And it increases in proliferative phase. In early proliferative, it is about 4 to 6, and in late proliferative phase, it is increasing. And in a excretory phase, it is at its maximal thickness over here. And in post-excretory, which is the pre-menstrual phase, it is variable. It is variable. So these are the measurements in different phases of the menstrual cycle. Now, endometrial thickness in different phases of life. In a childhood age, endometrium typically is very, very thin due to the lack of the estrogen stimulations. So in childhood, you will not see much of the endometrium. And in a reproductive age, the menstrual phase of the reproductive age, it is about 2 to 4 millimeters. It is thin just after shedding again. And in a proliferative phase of a reproductive age, it is about 4 to 10 millimeters. And in excretory phase, it is increasing. It is like we just discussed about the different phase of the life. Over here in pregnancy, it is, of course, it is increased. It is more than 12 millimeters, but it will be variable over here. In premenopausal, it is variable and irregular. So usually it is irregular over here. And in postmenopausal, here you have to see whether the patient is on HRT. If no HRT is there, then it has to be less than 5 millimeters. But if the patient is on HRT, then up to 8 is accepted. So if patient is not on HRT and it is 8 millimeters, that is abnormal. So on HRT, it is more than with no HRT. It is due to the hormonal therapy, which is maintaining the thickness over here. So interpretation depends on the regime. So these are the endometrial thicknesses in different phases of life as well as in different phases of the cycle. Now, the second question from Dr. Sakina Johar, who is from Madhya Pradesh, is that how to look for a cord round neck. Now, this doctor wants to know how to look for a cord which is around the neck. Second question, how to look for cord insertion. These are two different questions. One is how to look for a cord insertion, another is how to look for a cord round neck. And the third question, which is completely different, is that how to look for a coronal ectopic pregnancy. So these are the questions from Dr. Sakina Johar. First, there is a detailed class on the cord round neck. I think that this candidate has not yet completed the cord round neck class. It is strongly recommended to complete the class first, then go for any, this question. This is not a question itself, it is a topic, but I will take in brief. But I am requesting you to go to the class and complete the class of the cord round neck. It is about a 30 to 35 minutes class where we detailedly discussed about the cord round neck. We showed the patients also, live patients also, the cord round neck and the loop which is just lying around near the neck, how to differentiate it. So the question is posted. I have to reply it over here. Now, first of all, the cord round neck. In cord round neck, see, in cord round neck, first of all, the transverse section is important. Transverse section, not the longitudinal section. So transversely, you have to see through the neck, then only it will make sense. Otherwise, if you take a longitudinal section, maybe that you are hitting onto the cord which is just near the neck, not around the neck. That way you will be overdiagnosing a case. So the model again is that please complete the class first and then pose the question. So anyhow, transverse section is very important with color to diagnose or to rule out any cord round neck. So what will be you seeing on ultrasound is that there will be U-shaped loops which will be encircling the neck. And clinical significance is not much unless and until it is a tight loop. Then the next question will be here, how to look for a single loop or multiple loops around the neck. I'm again requesting you to go to the server class, which is in detail over there. So in brief, you have to take a transverse section, not a longitudinal section. Second question, cord insertion on the placenta. How to see for a cord insertion onto the placenta? Now see, the cord insertion onto the placenta is very important. In each and every patient, you have to see for the cord insertion. In fetal ultrasound course, we are having about 4 classes, if not 5 classes regarding this cord insertion, why it is important, how to see for that, what is the significance. So in brief, the cord insertion, if central insertion of cord which is normal, so you have to make sure that it is centrally inserted, because if it is not centrally inserted, it can be a battle door, which is also a filamentous cord insertion. Now, this filamentous cord insertion is very, very tricky over here, because if you see a filamentous insertion of cord, then you have to see for the the connection from the insertion of cord to the placenta. It can be direct, it can be indirect. If it is indirect, then it is very, very dangerous. It can be a vasoplavia case also. So scan first of all the placental surface in longitudinal as well as in transverse planes using color Doppler. Color Doppler will not show you the cord insertion, but unless and until you don't have a good grayscale image, then you have to superimpose a color onto the the good grayscale image, then only color will work over here. So the moral is that the placental surface has to be scanned both in longitudinal and in transverse sections using the color. That was the second question. Third question is that is regarding the ectopic pregnancy, which is precisely here discussed. Let me discuss the coronal ectopics. In coronal ectopics, now see, the point here is that in coronal ectopics, the gestational sac will be having some myometrium around it. First of all, the location where it will be somewhere in the corona. Now, there will be an myometrium around the gestational sac, but the important point is how much the myometrium will be around it is less than 5 millimeters, which is called as the interstitial line sign. So if you see an 5 millimeters, less than 5 millimeters myometrium, that is an interstitial line sign, which is very much typically seen in these coronal ectopics. So 5 millimeters, less than 5 millimeters, interstitial line sign seen will be suggestive of an coronal ectopic pregnancies. What I recommend here, the high resolution transvaginal ultrasound. So use a high resolution transvaginal ultrasound because sometimes you may not see a clear myometrium because it is very thin around the gestational sac. Thereby, you may not be, very much accurate in diagnosing the coronal ectopic. So use a high resolution vaginal transvaginal ultrasound to make or rule out a diagnosis of a coronal ectopic pregnancy. Now, the next question is Next question from Dr. Shantanu, who is from Kolkata, is the ovarian cancer. It is not actually a question; it is a class in itself. The two words will take me about 10 minutes. So ovarian cancer, what I am again requesting you that in gynecology ultrasound course, in detail we have discussed there how to make a diagnosis of an benign versus malignant case, ovarian I mean. So this doctor may not have gone to that class and have posed a question over here. We will take it in brief. So, first of all, what you have to see the morphology. You have to see the morphology. In ovarian CA, it will be multilocular and there has to be septations. Then only you will be thinking all lines of an ovarian CA. Next is the solid component. These things are in detail in class. Please revise the class, or maybe that you have not even touched that class. I'm just giving you a recap over here. Solid component. This solid component, if seen in a cystic area, now see, you see a mass over there, you see a cyst over there. In that cyst, there is a solid mass. That is also a strong predictor of malignancy. Now, this solid mass has to be, about 7 millimeters. If it is less than 7 millimeters, say it is 2 or 3, that is not going in favor of malignancy. And if it is less than 7 millimeters, it is going in favor of this mass. So again, it covered in detail in the class of the gynecology, where we have in detail discussed about these ovarian CAs. Now the papillary projections. The papillary projections, if seen, is highly suspicious for carcinoma. So see for any papillary projections and how much the papillary projections has to be there for. So less than 4 is not going in favor of, more than 4 is strongly going in favor of the ovarian CA. So how they will be looking like, the papillary projection, the echogenic protrusions in the cystic cavity. It will be like these, going inside the cyst, like the papillary projections going in. And how much? 4 and more. Then surface irregularities. Surface irregularities, lobulated or irregular outer counters is also going in favor of an ovarian cyst. Then ascites, of course, if you see an ascites in a patient with an ovarian mass, that is also going in favor of ovarian CA. Then your, Doppler. You don't have to start from Doppler, you have to end on the Doppler. So Doppler is showing the central flow with a low resistance index is going in favor of the ovarian CA. And the size matters here. Size do matter. If the overall cyst is 10 or more than 10 is going in favor of an ovarian CA, and less than 10 is not going in favor of ovarian CA. One criteria is not making or excluding a diagnosis. You have to put, multiple criteria in the basket before making the diagnosis. And if you see a bilateral involvement, sometimes it is seen in advanced cases, especially in these epithelial ovarian cancers. So see whether it is unilateral or bilateral. So this was a recap. I'm again repeating. This was a recap of an ovarian CA. For detailed class and explanation, please complete your gynecology ultrasound course. Next question from Dr. Toerete, I'm very sorry if I'm not pronouncing it rightly, is that, is there any trick to identify left ovary in TAS and TVS both? It is he. I find it difficult to see left ovary. So this is the question. So the question in a nutshell is that how to see for an ovary. Sometimes this doctor is not getting an ovary on TAS or maybe on TVS. First of all, I have told you in detail in the gynecological ultrasound course that the ovarian, location is not fixed. It will depend. Sometimes the ovary, right ovary will be here, left, you will not be exactly there. What you are expecting will be high up or lower down. So the ovarian location is not fixed. You have to search for an ovary. First of all, on trans-abdominal scan, make a note. First of all, on trans-abdominal ultrasound, you have to start the uterus to scan in sagittal view, in sagittal section. Start from the sagittal section. Keep your bladder full, which is helping you in penetrating the beam, I will say. Second is that you have to sweep, probe lateral to the left adnexa. Now see, lateral to the left adnexa. Third, landmark. Keep the landmark in your head. Landmark is the left iliac vessel. Ovary is just lying medial to it. So try to see for an iliac vessel. If you are not getting the ovary, try to see the left iliac vessel because it is the landmark over there. Then keep an appearance in the mind, because not always the ovary will be round or the other shape. Usually it has to be the oval structure with small anechoic fluids, these follicles, I'll say. Because why I'm saying this appearance? Because sometimes you'll be cutting the muscle or any tissue over there, and if you are seeing it more of round, then maybe that it is not an ovary. So keep the appearance in your mind. Then the tip over here is that apply a gentle pressure. Apply a gentle pressure, not a hard, gentle pressure. Why? Because you want to displace the bowel gases. So apply, sometimes you may have to apply a gentle pressure over here. In TVS, again, you have to begin from the sagittal section, it means from the longitudinal section, then rotate the probe towards the left thigh to sweep in the left adductor. You have to be very clear about the anatomy, sonoanatomy, I mean. Ultrasound is not about the photography, it is the real test of your neurons. So apply your anatomy onto the screen. That is the sonoanatomy. So here you have to rotate the handle towards the patient's left thigh to sweep into the left adductor. Then the landmark, the ovary is lateral and posterior to uterus over here, and sometimes it will be cranial. So you have to understand, you have to now, you are matured enough now. If you have completed the course, you are matured, you know what I mean by the lateral oblique posterior to uterus, and sometimes it will be cranial. And appearance, again, you have to see for the stroma, and there will be multiple small follicles over there. And tip here is that use a color Doppler to confirm that there is an ovarian vessel and differentiate it from bowel. So the teaching notes over here is that symmetry check. Compare with the right ovary for orientation. We are right now talking of the left ovary, how to scan the left ovary. So here you have to compare it with the right ovary. Probe manipulation, small, rotations, small rotations and annulations sometimes reveals the hidden ovary. And patient's position. It is also important. Slight tilt, or the bladder adjustments can improve the visualization. So these are the teaching notes. To scan, to get a ovary in a given case, we are talking of the left ovary, because this question was about how to identify the left ovary. Next question from Dr. Bhagyashree is that how should I differentiate CBD stones from CBD tumor? Now see, first give a thought. If there is a stone, what the ultrasound picture will look like? And if there is a CBD tumor, what that will look like? The stone, first of all, the stone will be hyperechoic. The tumor will not be always hyperechoic, it will be hypoechoic. The stone will have, defined contours. The tumor will not have defined contours. CBD stones will give you acoustic shadowing. The tumor will not give you acoustic shadowing. The CBD itself will have abrupt tapering. Where is the stone? Then there will be abrupt tapering. Whereas in CBD tumors, it will not be there. So these are the practical tips which will make you understand whether this is a stone or a tumor. Now, let me elaborate this. First of all, echogenicity. So CBD stones are more hyperechoic. Try to understand. It has to be more hyperechoic as compared to the tumor. Whereas the CBD tumors, those are hypoechoic or sometimes isoechoic, but it will never be hyperechoic. Margins. Just now I told you, well-defined and round or oval if CBD stones. And why a tumor will be having a well-defined area? Why the margins will be well-defined in case of a CBD? So CBD will be tumor CBD. Tumor will have an irregular or nodular surface, whereas the margins will be sharp in case of a stone. Now, one more thing. CBD stones, so stones can, change the position. So sometimes you will be seeing, not always, but sometimes if you see a mobility in an area, And if you are thinking all lines of a tumor, it is not tumor at all. Why a tumor will move? So CBD stones may have, I'm using word may have change in the position, so it will be mobile. So you have to change the patient's position to see whether it is mobile or not. And why a CBD tumor will have any type of mobility, so it has to be fixed only if it is CBD tumor. So location also matters. These CBD stones are often distal. Now see, try to understand, these are distal. So if you see a distal thing, then it is going in favor of the CBD stones. Whereas these tumors can occur anywhere. Tumors can occur anywhere, but if it is stone, it is usually at the distal CBD or maybe at apple. So ductal dilatation. Just now I told you in the start of this explanation that the ductal dilatation, proximal biliary dilatation will be there, and there will be abrupt cutoff at the stone level. So abrupt cutoff at the stone, at the area is going in favor of CBD stone, whereas gradual tapering or irregular narrowing of the duct is going in favor of tumor. And your magic stick, whatever you say magic stick, is not actually a magic stick, this color Doppler. Color Doppler is not with the start. So with color Doppler, you have to add the case. Then you will be putting sometimes the color Doppler to see whether there is a revascularity, and if there is a revascularity, that is going in favor of tumor, and why a stone will have any type of vascularity. So of course, the associated findings in CBD, many a times, not rarely, many a time, you will be seeing some gallstones. So if you see some gallstones and you are thinking on lines of a CBD tumor, think twice. It is usually seen in a CBD stone. So if you are thinking on lines of CBD tumor and there are some gallstones, you have to double check it. So this way, you will be differentiating whether I am dealing with a CBD stone or a CBD tumor. Now, the next question, let me go to the next question. Before next question, the diagnostic tips over here is that try to use a high frequency linear probe. So there is a linear probe. If there is a linear probe with you, so try to put a linear probe, because with the linear probe, the resolution is very high. The only backdraw or with these linear probes is that the penetration is the issue. So if the patient is thin and you are having a linear probe, try to put a linear probe, because the clarity will be very high with these linear probes. And if you are having any type of confusion, you can go for the suggestion for this MRC. Now, somebody is posting, what is this? So what is the name? Dr. Taseen Fatima is posting, is this a fibroid? Now see, we are not photographers here. One image will not make a diagnosis. You have to put multiple things. You have to put all your knowledge. You have to put your anatomy, your clinical knowledge over there, your probe orientation. So then we can make a diagnosis. So this is not accepted, but it is already passed to me. This picture I have to comment. First of all, see this thing. Looks like a fibroid. Looks like a fibroid. Why it looks like a fibroid? Because there are some calcifications. Looks like there are axial calcifications over here. Yes, going in favor of a fibroid. This area is hypoechoic. Goes in favor of a fibroid. So what will be the polyp echogenicity? Polyps are usually hyperechoic, because as is the father, so will be the son that is already covered in the glasses. Because these fibroids are derivatives of myometrium, whereas the polyps are derivatives of endometrium. Endometrium is more ecogenic as compared to myometrium. So the fibroids, which are derivatives of myometrium, will be hypoechoic. So looks like hypoechoic. Looks like there are some eggshell calcification. So these two findings are going in favor of fibroid. Third one, what can I make out with the stilt image is that the contours. Now see, the contours are regular over here. The contours are regular. Looks like it is going in favor of fibroid. So whether it is an intramural or a panmural on this still image, I cannot make out. But it is not a subserous fibroid. It is not distorting the the contours. Looks like a fibroid, but I have to see more cine lobes and more clips. But yes, it looks like a fibroid. Next question, how to differentiate clearly an unobliterated uterine cavity and a subchorionic bleed? Dr. Kalar Mana from Kerala is posting this question. For this, we have to recall all our early pregnancy classes. In our early pregnancy classes, we have discussed in detail about this unobliterated uterine cavity and how to differentiate it from a subchorionic bleed. Location first. Location here in unobliterated uterine cavity is central. Whereas in case of an hematoma, it will be not in the center always. Relationship to the gestational sac. So if it is an unobliterated uterine cavity, I know who has not completed the early pregnancy ultrasound course may not understand what I am saying about. But those who are already have completed the early pregnancy ultrasound will understand me better. So a relationship to the gestational sac here is, within the cavity. Sac lies within the cavity. Cavity surrounds the sac. Whereas over here, it is often lifting the chorion up. Over here, the appearance. The appearance here in unobliterated uterine cavity, it is, not the blood. Try to understand. In unobliterated uterine cavity, we would have blood. So it will be anechoic or hypoechoic. So it will be isoechoic. Whereas here, it will be heterogeneous because sometimes I will have old blood, fresh blood, clot over there. So here, the question of heterogeneous does not arise. So the appearance, the echogenicity is telling me the shape. Shape here, it will be symmetrical. Whereas here, it will be crescentic. The margins here will be smooth because it is not a hematoma, it is an unobliterated uterine cavity. So the margins has to be smooth over here, whereas the bleed will have an irregular margins. Clinical context, it is normally seen, this unobliterated uterine cavity is a normal finding, which is seen in a very early pregnancy. Whereas if there is a subchorionic bleed, it is associated with the risk of the miscarriages, and the risk depends on the size. So the take-home points is that unobliterated uterine cavity is usually seen in very early pregnancy. I am using the word very early pregnancy, whereas the subchorionic bleeds appears as a separate hypoechoic area outside the sac, which is lifting the chorion. So the probe manipulations, sometimes sweeping in multiple planes, helps to confirm whether I am dealing with this or that. So clinical correlations, you all know that the subchorionic hematomas are linked with the threatened abortion, whereas the unobliterated cavity is a normal early pregnancy finding. Last question, probably Dr. Anita from UAE is posting how to diagnose anterior posterior wall submucosal fibroids. That is first. And the second is how to diagnose ovarian torsion. This candidate, Dr. Anita, has not yet completed the class. I am very much sure has not yet completed the class, all classes, I mean, of gynecological ultrasound. Otherwise, question would not arise. So now, if we are talking of the fibroids, anterior wall fibroids will distort the anterior uterine contour, and it can compress onto the bladder also. So if you are seeing a distortion in the anterior uterine contour, it is an anterior fibroid. It can be due to the anterior wall fibroid. And posterior will distort the posterior contours and can compress on the rectum. So if patient is having, just to give you a clinical, correlation, if patient is having any urinary incontinence, that can be due to the anterior wall fibroid. And if patient is having, something related to the rectum, maybe she's having some something which is not regulating her. That is due to the compression on the rectum. So you have to see it clinically also. Now, the submucous fibroids are protruding into the endometrial cavity. These are very dangerous fibroids because if there are submucosal fibroids, patient may have many clinical findings, and if it is an infertile case, that can be due to the submucosal fibroids because it is protruding into the endometrial cavity. And intramural is within the myometrium. So if you see a hypoechoic mass, like we just now saw a fibroid where somebody was posting whether it is a fibroid or not, that was intramural and neither distorting the contour nor compressing onto the endometrial cavity. That is the intramural. So subserosal is projected outside the uterine surfaces. These are pedunculated, and sometimes they can mimic, the adnexal masses. So these are different types of fibroids. Then coming to the ovarian torsion, the next question, ovarian torsion. First of all, the size. The size of the ovary will be increased. Why it is increased? Because I am having a congestion over here that can be due to the venous or the lymphatic congestion. So overall ovarian size will be increased. Follicular pattern. So peripheral displacement of the follicle, the string of appearance will be very much prominent over here in case of ovarian torsion. Stroma here will be hypoechoic. This again is due to the edema or sometimes the hemorrhage. Color Doppler. Over here, if it is an ovarian torsion, the color Doppler will show me absent or reduced venous flow and sometimes the arterial flow also. So the color Doppler is essential for confirmation over here. Not always color Doppler is useful, but in some cases, you cannot make 100% diagnosis without a color Doppler. So in case of an ovarian torsion, the color Doppler, if showing an absent or reduced venous flow, is a very positive sign for you to make a diagnosis of an ovarian torsion. Whirlpool sign. So twisted vascular pedicles are seen on color Doppler, which is very much pathognomonic for these ovarian torsions. And sometimes free fluid is seen. If it is seen, it is also going in favor of these ovarian torsions. So the take-home message is that fibroid diagnosis, the location depends on the relationship to the endometrium and the uterine contour. Some mucosal fibroids are seen if they are distorting the endometrial strip, and ovarian torsions requires a color Doppler. Absence of the flow is more sensitive than venous is more sensitive than this arterial. Always correlate with clinical symptoms. This ovarian torsion, always you have to correlate with the clinical, symptoms when you are talking of this ovarian torsions. Do I have more questions? Yes. Now see, Dr. Sweta from Maharashtra is posting these questions, this set of questions. UNG findings of oophorytes, differentiate uterine AV malformation from how to differentiate placental dysplasia from trophoblastic disease, how is peritoneal fluid volume calculated, why RPOC's blood flow in transverse and not in longitudinal section. I told you these are copy-pasted questions. The language is original from the candidate. We even don't want to change the the language of the questions. So UAG findings of the oophorytes. First of all, the ovary. Ovary itself will be enlarged. So if you see an enlarged ovary with an heterogeneous hypotexture. Now see, this enlarged ovary was seen in the torsions also. So, but here the ovarian capsule will be thickened. And the vascularity, now see the importance of vascularity, color Doppler. I just now told you that color Doppler is very important for in those cases, because over here the vascularity will be increased, whereas in case of torsion, vascularity will be decreased. Sometimes the tubo-ovarian masses or abscesses can form, and it has to be have an association with the pelvic inflammatory disease, or you will be expecting some free fluid also in case of oophorytes. Now, the next question is differentiating, how to differentiate an uterine AV malformation from an RPOC. Now, see, the AV malformation, where you'll be seeing these malformations is in the myometrium. Now, try to understand here, in the myometrium, whereas these RPOCs are in the endometrial cavity. So location matters here. And Doppler, now see, this Doppler will show me high velocity with low resistance. It means that this diastolic flow is more. Whereas in case of these RPOCs, it has to be moderate and usually low velocity. So high velocity is going in favor of AV malformation, but location matters over here. This is in the myometrium and this is in the endometrium. Location is intramyometrial, whereas the location in RPOCs is endometrial cavity. So, of course, the clinical correlation, if the patient is post-pregnancy or post, curettage, then you'll be thinking on lines of uterine AV malformations. Whereas if it is post-delivery or abortions with bleeding, then it can be a case of RPOCs. I told you in the beginning that we will not show you much of slides over here because these are question and answer sessions in detail. We are covering all these topics in the course. The enrollment drawings. Okay, what is next over here? So next is how to differentiate the placental dysplasia from a trophoblastic disease. Now, first of all, appearance. First of all, the appearance. The placental dysplasia will be localized. Try to understand. It has to be localized abnormal tissue. Localized over here. Whereas trophoblastic disease will be diffuse. So Doppler here helps me by showing a variable or maybe a reduced flow over here. But in case of this trophoblastic disease, it's markedly vascular with a high velocity flow. So clinically, focal placental abnormality, and over here, the elevation of the beta SCG will be seen with the uterine enlargement. So last question is peritoneal fluid calculation. Now see, it has to be quantitative. Let's be frank, it has to be quantitative. First of all, it has to be quantitative. What we are taking a rough estimate of the volume by the depth of the fluid in the pelvis, which is measured over there. So it is the rough estimate of the volume, and we use the formula to calculate the quantity by taking the depth, width, length, and the correction factors. So in practice, we give the minimal, moderate, and massive. We cannot exactly measure the peritoneal fluid. So this is a rough calculation where we are giving the minimal, moderate, and massive fluid calculations. Next is why RPOC flows are seen in transverse sections. So this is a very good question. I appreciate this question. Why RPOC flow is seen more in transverse section is because the vascular channels in RPOC are oriented itself in the RPOC. They are oriented across the endometrial cavity. So try to understand. The reason is that the exact orientation of these vessels in RPOC is transversely across the endometrial cavity. That is why it is more better seen in transverse sections. In longitudinal planes, you may miss due to the angle dependence. So, teaching notes, always use color Doppler to differentiate vascular lesions, that is AV malformations, from RPOCs. Snow pattern is the classic for trophoblastic disease. Transverse Doppler orientation is the key for RPOC valuations. And of course, the clinical correlation, that is the history of pregnancy, rate, bleeding, is essential for accurate diagnosis. So this is all for now. I am having something else. Now, let me clear everything first. Now see, what is this? I have read that in grayscale, angle should be used for 90. Let me first read this very quickly. 90 degree, but in knowledge, separate, discuss. Oh my God. Dr. Gurdarshan Iqbal Singh from Punjab is trying to understand. I got him. Is trying to understand the complete physics. I appreciate. This is very good. This is a good sign. Look, if we will talk about these all points, it will take 15 to 20 days. These points only. And whole of the physics actually is a 6 months course, not available with BIMNET. Because if we start a 6 months course of SPI, these are SPI questions, which have been posted by Dr. Singh from Punjab. These are SPI questions. If you are very much interested, you have to register yourself for a 6 months course with ARDMS. We are the first to introduce the physics to this Indian subcontinent, and we are giving a very basic of physics. And if we start talking of physics, then it has to be a minimum of 6 months, and people will not tolerate it. So let me take one question. Let it be the starting one. Yeah. Now see the question here. First one. In grayscale ultrasound, angle should be 90 degree for better resolution with the organ striking the beam, but should be lesser than 60 or 60 in Doppler. So he means that when anybody is scanning the grayscale, the angle has to be 90. Very good. But in case of a Doppler, the angle has to be 60 or less. Very good. But my question, it is his question, but my question is without actually seeing the angle. Try to understand his question. These are very good questions. But Indian subcontinent doctors will not digest more of physics. They will run away. But bear with me for a couple of minutes with this physics. But his question is that seeing the exact angle of beam when it is inside the body and hitting the vessel at 45 degree. How can I know that it is 35, 45 or 60 or maybe 100 or maybe at 90. Are you able to understand his question? His question is that how can I make understand to myself that I am hitting with a 45, 60 or 35 because it is something which is inside the body, how I can go over there and measure whether it is hitting with 90 or 60 degree. So let me take this question. Dr. Singh, keep it up, very good, appreciate it. But it will take some time. You have to go far, and I think that this doctor is trying to go to US to clear the ARDMS, but you have to be very, you have to do a hard work for that because in US they first you have to clear the SPI, that is the physics, then the clinical side. Now, see, coming to the first question. This is the vessel. Now try to understand. This is the vessel. Only vessel. Over here, it is the aorta. So only vessel over here, in given case, the aorta, the beam is coming this way. Now see, the beam is coming this way. Now, this part, try to understand. This part of the vessel is headed by about a 90 degree. Now, you don't have to measure it. You don't have to put a scale on the ultrasound monitor. But visual impression is telling me that this part, now see, this part is being hit by 90 degree. Whereas the flow in this vessel is this side. And I am hitting it this way. So this angle, now see, this angle is about a 45 degree. You don't have to bend your body like this and that. You don't have to lean on the patient to make this angle. Automatically, in a single vessel over here, in case of this aorta, some part is hit by 90 degrees, some part is hit by 45, some part is hit by 30, some part. So lower the angle, more acute the angle, good is the flow. And if it is at the right angle, 90 degree, it is worst because now see, this is the vessel over here. The flow is this way or that way. But the point here is that I am hitting with this way because this is the footprint of the machine. This is the footprint. So the beam is hitting this way. That is why in this vessel, I am not able to see the flow because this vessel is automatically getting hit by 90 degree. 90 is a good angle for 2D ultrasound, but 90 is worst angle for Doppler. So this way, you can make out whether you are hitting with 90, 45, or more acute or 90 degree. Now, see over here. From here, try to understand here. The beam is coming this way. See, beam is coming this way. The vessels, the bunch of vessels over here are not getting hit by 90 degree. Now see, bunch of vessels over here are not getting hit by 90 degree, but the vessels over here, try to understand this part, they are hit by a 90 degree over here. That is why in this part, I am not seeing any color, whereas across it is seen over here. I am erasing, see it yourself. I am not seeing any flow where the beam is hitting the 90 degree, but lesser the angle, better the flow is seen on ultrasound. Now, see over here. These are hepatic veins. No, forget about hepatic veins. This is the vessel. This is the area over here. Over here. Now see, try to, this is very beautiful image. In this vessel, this is very clearly seen on ultrasound. I mean, grayscale ultrasound. This is very clearly seen. So I am even seeing the walls over here. Now see, the walls are very much seen over here. I am not seeing very clear picture over here. I am not seeing very clear picture over here. Now I am putting you a question. You means everybody. On grayscale, the 90 is the good angle. 90 is the best angle. That is why I am seeing even these walls over here. And this is the vessel which is getting hit by 90 degree on grayscale. I am yet to put Doppler over here. Now, because 90 degree is very good for grayscale. But this 90 degree is worst for color Doppler. Now question, let me label this. Let me erase first. This is vessel number 1. This is vessel number 2. And this is vessel number 3. In vessel number 3, I am seeing very good grayscale image. Vessel number 1 and 2, I am not seeing a good grayscale image. Let's post in the comment box now. If you put a color Doppler, which vessel will show you a good flow? First one or third one? In your comment boxes now. Forget about second one. Okay, take second one. Forget about this one. The second one or third one. If you put a color box onto this image, will you see a good flow in third vessel or second vessel? In your comment boxes now, hurry up, 10 seconds only. Dr. Prince Shaila, third one. Dr. Fatima, first and second. Dr. Pooja, second one, third one. Very good. Now see, if you put a color Doppler, you will not see a good flow in third one because this third one is having an angle which is near to 90 degree. Whereas this second one is having a lesser angle. Now see, this is having a lesser, let me erase all these things first. So this is having a lesser angle. Now see, this is having a lesser angle, whereas this is having a more perpendicular angle. So lesser angle, good for Doppler. You are hitting by 90 degree, you will not see much of color. You are hitting with 90 degree, you are seeing a good grayscale image. So these are the angle which are being hitted automatically by your ultrasound whenever you are scanning. Now see, over here, I am not seeing a good color over here. So, but in this vessel, I am seeing a very good color because this vessel is not getting hit by 90 degree. Whereas this vessel is getting about a 90, maybe a 95, 96 degree. So perpendicular, not good for grayscale. For color, perpendicular, you have to hit when you are taking the grayscale image. So these were all questions which I hope that I have done justice with these replies. Thank you very much. But again, requesting all of you to first complete the topic. Now see, first complete the topic, at least touch the topic. At least touch the topic before posting a question, because I am taking these classes in detail. And if you don't even touch the class and post the class, that will be a class over in these interactive sessions. So next time, please at least start the topic before posting your question. Thank you very much. God bless all of you. We are taking these types of question and interactive sessions at regular intervals. For about a week, I am going to Russia and Baku for a CME. So I will not be available for about 10 days, but after 10 days, we'll be again taking these interactive sessions. Stay tuned. God bless all of you. Thank you very much.